Um, all right, so let's get started. So today we're going to start off with the endocrine stuff, the endocrine system. There's a little short intros by me, probably going to take like 10 minutes max, and then the rest of it's basically Alina, and she might talk about HPBM as well at the end of it. As I've said a couple of times now, if you have any questions, put them in the chat, message us, or just put them into the Zoom chat. If there are any bits and pieces that you were really confused about, put them into chat as well, so we can like pay, I guess, more attention to them. But yeah, this shouldn't be too bad. So let's get started. So, introduction. So, effectively, the endocrine system is basically just about communication, and it's the combination of, well, it's one of two systems, where the first being the nervous system, which you guys should be fairly aware of, which is instantaneous but is rapidly degrading, versus the endocrine, which is composed of endocrine organs and is within circulation and is delayed. And critically, it's also got low concentrations of hormones with high affinity receptors, whereas in the neurotransmitters, these are all high concentrations in that synapse with a low affinity receptors. These will work together to kind of sense what's going on in the body and kind of those homeostasis. A lot of the pathways you'll see in endocrine are like these negative feedback pathways. Next semester with the female physiology, there may be some more positive feedback loops, but most of these are going to be negative feedback loops, and they're kind of detected through these kind of organs. But the detection isn't kind of the important bit for you guys. It's more about the response and what they do. Effectively, the endocrine system produces the hormones that all cells are exposed to, something they call the endocrine milieu, if you care at all. These are basically a lot of organs, but the ones we will talk about and focus on a lot are the hypothalamus, the pituitary gland, the pancreas, and the thyroid, the parathyroid. There are also a whole bunch of other endocrine organs, like the skin and the fat also count, but they aren't the classic endocrine organs that are described, I guess. There are three kind of overall groups, and this is sort of important because they have different sort of properties, and these will basically have different characteristics in how they move through your body and how they act upon cells to do the action that they've desired. So these are the amine thyroid groups, the peptide, a protein, and the steroid hormone hormones. Their concentration in the blood is basically determined by how much they're produced, so synthesis and secretion, rates of removals, how much they're removed, and the amount of hormone that's bound to plasma, or proteins, I should say. So how much of the hormone is bound to something. And effectively, the more things are bound, the slower the degradation of that hormone will be, because they're very much protected almost by that protein that they're bound towards, because you can only remove things when you have it freely floating in your blood. It's also only active or doing something when it's also freely floating in your blood, though. The synthesis and secretion rate is important because different hormones will have different secretion patterns, such as diurnal or a pulse pattern. Things like cortisol are diurnal pulse, diurnally secreted, and these patterns make detecting the hormones problematic in some conditions. But we'll touch upon that in more detail when we get to each of the separate hormone pathways. But firstly, we'll go and look at these. So steroid and thyroid hormones. So amine hormones are derived from amino acids, and these include just thyroid hormones and the catecholamines. So thyroid hormones will act similar to steroid hormones, with the exception of this one difference that we'll talk about in a sec. You can almost treat them exactly the same in terms of what they do. Catecholamines act a lot more like protein hormones. So steroid hormones are synthesized in the mitochondria and the smooth endoplasmic reticulum from cholesterol, and are not stored, but rather just continuously diffused out. The increased secretion in a minute or so, the maximum is about 10 to 15 minutes, but the most important thing is that they aren't stored. The rest of the amine peptide protein hormones will be synthesized in the endocrine cell and stored before being exocytosed. Some of these are made as pre-pro hormones, so I guess basically two stages of cleaving. So pre to become a pro hormone, and then the pro has to come off to become a hormone. And those go through like protein cleavage stages, which depend on the specific hormone itself. Then steroid and thyroid hormones generally, these circulate the blood bound to larger carrier proteins, and only the small unbound part will be chemically active, but also that part will be able to degrade it. What this means there's a large proportion that's bound, and basically when some of it's used, some more of it will come off of the protein, and that will, I guess, effectively replace the pool of hormones that is in the body. So effectively, there's a very stable concentration because what's taken out from the blood is put back in from the protein stores that's already there. It's almost like a chemical equilibrium sort of idea, if you remember back to like year 12 in high school. This is because they're hydrophobic and thus will diffuse into cells, targeting intracellular receptors because they can't, I guess, float in the blood because they just won't float in the blood because they're hydrophobic. This is a diagram for that. So you can see they're kind of coming into the cell to do their thing and bind to their receptors. This is in contrast to peptide, protein, and catecholamine hormones. Catecholamine hormones are a type of amine hormone. These are hydrophilic, so in contrast to these hydrophobic hormones, the thyroid and thyroid hormones, and they dissolve in the plasma at low concentrations. They can be bound, but they don't necessarily have to be. But these will generally bind to surface receptors because they can't go through that sort of cell wall. This is just a general sort of overview of all endocrine disorders. Obviously, we'll go into each of them in more detail, but these are the general principles that occur. So endocrine disorders are because of either an increase or a lack of a particular hormone. Sometimes it's also a problem with the receptors involved. A lot of the time you can do hormone testing as well as imaging. So MRI, CT, or ultrasound. MRI is particularly good for things such as pituitary tumors in the brain. And that's the other thing. Rarely they can be a result of ectopic tumors. So if you ever heard of pheochromocytomas, those are kind of tumors that produce excess adrenaline, things like that. Then are an example of an ectopic tumor. And these can occur at all stages of life. So they can occur during youth and they can occur during adulthood. But we'll go through those in a lot more detail as we go through each. But that's effectively all I had to say. I don't imagine there were heaps of questions from that. But if there were, put in the chat. Otherwise, we'll move on.
I think the most important thing to remember in terms of the types of hormones is just that you have like your fat soluble / steroid / thyroid hormones. And because they're fat soluble, they can't float freely in your watery blood. So they need a carrier protein, but they can diffuse freely across your fatty membrane versus your peptides / whatever water soluble amine catecholamine hormones, where they are water soluble. So they can float in the blood freely, but they can't float directly across the membrane freely. So they require a transmembrane receptor. It comes all down to the whole water and fat soluble situation, if you guys did biology. Pancreas and diabetes. So I will share my screen once I figure out where to present. Okay, I got it.
Cool. But yeah, those are the kind of main ideas. So out of the 6 slides, the idea of when hormones are to cross and when hormones have to be bound to sort of proteins is kind of the big idea. Apart from that, there's not a whole bunch there. It's critically accessible.
Yep, pretty much. Yeah. Okay, pancreas and diabetes. So this is an overview of the endocrine function of the pancreas. So the pancreas has a lot of hormone producing functions. It has exocrine roles in terms of secreting hormones or more so enzymes for digestion purposes. And then it has an endocrine function. And these are sort of the 4 endocrine functions here, produced in different parts of the pancreas. And then different hormones have different effects, obviously. In terms of diabetes, the ones that we really care about are glucagon, produced in the alpha cells of the islets of Langerhans, and insulin, produced in the beta cells of the islets of Langerhans. But just keep in mind, there are also delta cells that produce somatostatin, and that's like a inhibitory signal for gastrointestinal system. And then PP cells that produce pancreatic polypeptide, and that's much less important, but it's basically self-regulation of the pancreas. Really though, we just care about glucagon and insulin. So the functions of insulin and glucagon, they're basically antagonists, so they work against each other. When you have increased blood glucose, so for example, after a meal, insulin gets secreted by the beta cells of the islets of Langerhans of the pancreas. And insulin is an anabolic hormone, which means it's going to increase our energy storage and therefore decrease the blood glucose levels. And it does this through a number of different actions. The ones that we usually think about are increasing cellular uptake of glucose, and it does that by increasing the number of these transporters in the membrane so that they can take up more glucose. But it actually does have other roles. So it stimulates glycogenesis and proteogenesis, and basically increasing energy storage through those means. And it also stimulates lipogenesis, so creation of fat for energy storage. And then it inhibits the opposite. So it inhibits glycogenolysis, the breakdown of glycogen, and gluconeogenesis, the production of glucose in the liver. And so it makes sense. It's basically increasing the production of things that will help us store energy, and then inhibiting the production of free glucose, because obviously we don't want that in the blood. And then glucagon, you can just remember as the opposite. So it's released when we have low blood glucose. So for example, first thing in the morning when you've woken up and haven't eaten for like 10 hours. And it's a catabolic hormone. So it's going to promote breakdown of our storage molecules and therefore increase our blood glucose levels. And its actions you can see are basically the opposite of insulin. It increases gluconeogenesis, so that glucose production in the liver. It stimulates glycogen breakdown, and it stimulates fat breakdown, lipolysis. So this is that sort of diagram where we have homeostasis and then disruptions going either way with your glucagon and your insulin, their respective functions, and restoration of homeostasis. So what is diabetes? Diabetes, you probably already know because it's very commonplace, but it's a syndrome of disordered metabolism and inappropriate hyperglycemia, secondary to either an absolute or relative deficiency of insulin, or a reduction in the biological effectiveness of insulin, or both. So it can be a problem with insulin secretion, or it can be a problem with insulin action, or it can be both. These are the diagnostic criteria, basically various serum glucose measures: fasting glucose above 7, random glucose above 11.1. HbA1c is our most accurate measure of blood glucose levels, and that's because it sort of measures glycemic control over 3 months. So if someone sort of had very poor diabetes control, but they've fasted for like 1 day or something before they get the test, then their fasting glucose will be very low. But the HbA1c can still be very high if it's been a long period of poor control. So this is going to be your most accurate measure. Here's some epidemiology. It's honestly not that important. Basically just know it's very, very common, and it's mostly type 2 diabetes. It causes a lot of death, and the incidence is increasing, and people are getting diagnosed earlier on in life, especially with type 2 diabetes.
For that, could you go back? For the diagnostic criteria, it's actually really quite important to remember, just as general, as well as just like our exams. So the way I kind of remembered it is like, I think I went like 7-Eleven. So 7-Eleven as in like the petrol station, or like the, I don't know what they're called, convenience store. 7 is the fasting, 11 is your random glucose. Then HbA1c is very close to 7, but to 6.5. So that's kind of how I remembered 7, 11, and 6.5 for these diagnostic criteria. And that's kind of important for you guys to remember.
Yeah. So type 1 diabetes. So type 1 diabetes is immune-mediated beta cell destruction, usually leading to an absolute insulin deficiency. So these people will have very low or completely absent insulin levels in their blood, and it's due to destruction of the beta cells. It's a combination of 2 factors, and the exact pathophys is not really well known, but the idea is that we think there's some combination of genetic risk. So people who have family history or personal history of autoimmune diseases, and then that combined with some kind of environmental trigger. So people might not necessarily have any family history or personal history, but they can still get type 1 diabetes, and we think that that might be due to environmental triggers like viruses or toxic chemical substances that cause the immune system to basically dysfunction and start attacking itself. An important thing to know with autoimmune diseases is that if you have one autoimmune disease, you're at much greater risk of all of the other autoimmune diseases. So it's often good to ask if people have a history of any autoimmune disease. And examples include Graves, Hashimoto's, celiac, pernicious anemia, IBD, anything like that, that actually predisposes them to other autoimmune diseases like type 1 diabetes. This is classically, it has 3 stages. So there's a long pre-symptomatic period well, relatively long. It can last years. And during this time, this unknown trigger has triggered the development of our antibodies against our beta cells, and that's progressively causing loss of beta cells and therefore insulin. And this can last several years because the insulin actually has to drop quite low, and the beta cell number has to drop quite low before people start to get symptoms. In the early phases, the beta cells will actually overcompensate, and they won't have any symptoms for quite a while. And this is why it's also so hard to identify the exact trigger and the exact pathophys, because we know that the trigger point can happen well before someone actually presents with diabetes. Then after people get diagnosed, there tends to be a short honeymoon period, a couple months to maybe a year or so. And during this time, essentially what's happened is because they've just been diagnosed, they still have some beta cells that are functional. So they're still early on in the disease. And we're suddenly giving them insulin, and that's helping to basically maintain quite good glycemic control with really minimal effort. So these people, they'll develop some symptoms, go on some treatment, some insulin, and then their symptoms completely subside for a couple months to maybe a year. But after that, all the remaining beta cells get destroyed, and their symptoms sort of pick up again, and they have to increase their doses of insulin and things like that. And that would be your symptomatic period. So the clinical presentation of it, so just focus on the bits in bold, that's your clinical presentation, but I've put in sort of the pathophys behind it and how these things happen, because I think it's good to understand. So essentially, type 1 diabetes has been described as starvation in the midst of plenty. The idea is that you have plenty of blood glucose, and these people will try to eat because they'll feel hungry, but that glucose can't get into the cells, right? Because there's no insulin to help transport the glucose into the cells. And as a result, their cells and their body tissues are starving. So you get glucose buildup in the blood, obviously hypoglycemia, that's what we detect on our tests. And those glucose levels, they exceed what is the transport maximum in the renal tubules. So our renal tubules, they excrete out glucose and then they reabsorb it, right? If we have plenty of glucose in the blood and therefore going out into the filtrate, it can't all get reabsorbed, right? There's too much. And so we end up getting glucose excreted in our urine, and that can be detected on a dipstick as glycosuria. And if we have glucose in the urine, that's going to increase the osmolality, and therefore you're going to get osmotic diuresis. So that glucose is going to start pulling water out with it. So they get polyuria, peeing lots. And because they're peeing lots, they get dehydrated, and therefore they get polydipsia, feeling thirsty all the time. On the starvation side of things, because our cells are being deprived of glucose, they get weight loss, or in kids, they fail to gain weight and they feel weak and lethargic because they don't have any energy. That obviously causes them to have polyphagia, which means they're hungry all the time. And then we get all of these other problems. So the liver tries to compensate by breaking down glycogen, because the liver thinks there's no glucose, when in actual fact, there's plenty of glucose, it just can't get in. So the liver's like, let me make more glucose. So it makes more glucose, and that in fact actually just worsens the hypoglycemia, right? We also have sort of alternative methods of getting energy, and that's sort of what the body turns to. And one of those is fats. So fats get mobilized for ketogenesis, and that causes a bit of hyperlipidemia because we're using our fats and putting them into the blood, and also the production of ketones. So when we break down fats for energy, we produce ketone bodies and keto acids, and that will cause a metabolic acidosis, and that's one of the acute complications of type 1 diabetes. It's called diabetic ketoacidosis. The ketones also get excreted in the urine, and that should say lungs. So we can detect ketones in the urine, and you can also get this weird like acetone smell on the breath. Proteins also get broken down in the muscles to produce amino acids for gluconeogenesis as one of those sort of alternative pathways. And so they can look quite thin and wasted. This is in comparison to type 2 diabetes. So the main thing to remember is sort of that underlying etiological difference. So type 1 is an autoimmune condition. Type 2 is more of a metabolic disorder. And this is primarily caused by resistance to insulin action and or impaired insulin production. And there's several sort of stages that we've identified as like the flow of the pathogenesis. So you start off with insulin resistance, and this is sort of, it's hypothesized to be connected to like obesity and metabolic syndrome and things like that. And the idea is that like if you constantly have an abundance of insulin around, then receptors are going to maybe decrease their affinity for insulin, something like that. So over time, we lose our receptivity to insulin and they become defective and they don't respond. Because of that, the body tries to make more insulin. So we get compensatory hyperinsulinism. And during this time, the patient isn't going to be symptomatic because again, the body is trying to compensate. So we get compensation, and then eventually, because these beta cells are trying to produce so much insulin, you get beta cell dysfunction, right? So they begin to atrophy and they become defective. So now not only are we resistant to insulin, but we also have issues with insulin secretion. Eventually, that can lead to complete loss of insulin. And so type 2 diabetics can become insulin dependent, just like a type 1 diabetic. But that's late stage if it's been poorly managed. Risk factors for type 2 diabetes. Probably the big one to know is genetic predisposition. So everyone seems to think that like type 1 diabetes is the big genetic one because it's autoimmune. But actually, and they love asking about this, but actually type 2 diabetes has the strongest genetic link. There's like a 90% concordance between identical twins compared to like 50% or something for type 1. So there's a very strong link. If someone has family history, they have quite a high risk of having it themselves. And then there's a lot of sort of lifestyle metabolic things. So obesity is a risk factor, lack of exercise is, old age is a risk factor for most things, but you can't even really say that for type 2 anymore because we're having a lot of obesity in children and as a result type 2 diabetes in children. Hypertension and stress, just sort of classic vascular problems again, dyslipidemia, cardiovascular disease, cystic fibrosis, Cushing's, and PCOS. Those ones are a little bit weirder. PCOS, when you learn about it, you will learn that diabetes is sort of one of the conditions connected to it. And you might remember Cushing's wise, one of the features is glucose problems and insulin resistance, and that can predispose to type 2 diabetes as well. The clinical presentation of type 2 diabetes. So most people with type 2 diabetes are asymptomatic for the vast majority of the time, and it's picked up on screening or it's picked up when complications start to arise. And we'll talk about the complications in a second, but they're really important to know about for diabetes. So this is some of the examples of things that people might come in with, but on the whole, they tend to be asymptomatic until we get our problems. So blurred vision can be a sign of retinopathy. They might have immune issues, candidal infections, skin infections, UTIs. They might have neuropathies, so paresthesias. They also can have your classic diabetes triad, polydipsia, polyphagia, polyuria. And this one, acanthosis nigricans, is like a bit of a buzzword. It's a skin condition basically where they get like hyperpigmentation in like skin folds, so like the back of the neck and things like that. And it's just like a darkening of the skin. It can happen with type 1 diabetes as well, but it tends to be associated with type 2 diabetes, as most complications are, because type 2 diabetes tends to present late. Whereas type 1 diabetes, it comes on suddenly, it's very acute, and people get treated quickly. So you get less sort of complications with it.
Just with the infection, with the infection thing, like as well as it weakens the immune system, but it also, because there's like an excess of glucose, it means that a lot of those opportunistic organisms also have like extra nutrients to like grow and sort of thrive. And the UTIs are especially common because you've got that polyuria, you've got a lot of glucose in the glycosuria. So UTIs are like way more common as well.
Yep. And UTI is also a complication of one of the medications we'll talk about in a second. Essentially, if you have glucose in the urine, you can imagine the bacteria will thrive on that. So I've just written here, the pathophys is largely the same as type 1 diabetes, but there is one really important thing to note, and that is that you do not get diabetic ketoacidosis in type 2 diabetes. And that's because there are still small amounts of insulin present and still small amounts functioning. So there's enough that the cells are not resorting to lipolysis and ketosis. They still can get sort of enough to kind of keep them going. So you don't get diabetic ketoacidosis, you get a different acute complication. So here is a bit of a table comparing type 1 and type 2 and some of the key features. The important thing to keep in mind is that this is like, it's kind of like stereotyping. So you can't really use it as like textbook, but it tends to be the case. So type 1 diabetes tends to be more sudden, whereas type 2 diabetes is a slower, more insidious onset. Type 1 tends to be diagnosed younger because it's a genetic problem, whereas type 2 diabetes typically older, but remember the incidence in younger people is increasing because of childhood obesity. Type 1 diabetics tend to be thinner or normal, whereas your type 2 diabetics tend to be obese because it's associated with the etiology. And then ketoacidosis is common in type 1, very, very rare in type 2. Autoantibodies, so this is sort of like the indication of an autoimmune disease, can be tested for in the blood, and they'll be present in type 1 and absent in type 2. Endogenous insulin will be low or absent in type 1, remember, because it's a failure of insulin production, whereas it can be all over the place in type 2 because it's a failure of insulin action, not production, primarily. And then we have our concordance. So they love to test this again. It's actually higher genetic concordance in type 2 diabetes than type 1. And the prevalence, again, type 2 diabetes dominates. Okay, so this is your acute complications. This is pretty important to know because they love asking about diabetic ketoacidosis. So diabetic ketoacidosis is your complication that occurs in type 1 diabetes. Hyperosmolar hyperglycemic state is really a completely separate condition in type 2 diabetes, but there tends to be some overlap so people get them confused. But actually the underlying mechanisms are completely different. So we'll start with diabetic ketoacidosis. And the problem in diabetic ketoacidosis, as the name kind of suggests, is that you're getting a metabolic acidosis due to the production of keto acids. And remember, keto acids are produced from fat breakdown when your cells become desperate for energy. So that's why it happens in type 1. It comes on very rapidly and it also recovers very rapidly. So they actually have pretty good prognosis. These are some of the clinical features, essentially sort of like your classic diabetes features, but then also abdo pain and nausea and vomiting. Fruity smelling breath is that ketotic breath, that acetone on the breath. And this one is important, Kussmaul respiration, which is where they have like deep, heavy, labored breathing. And that's a feature of DKA that is not present in HHS, okay? And that is, again, because they're trying to compensate for the metabolic acidosis by breathing off their carbon dioxide, because carbon dioxide is acidic, essentially. Investigations, they will have high serum glucose, obviously. They will have ketones in the urine, and that's because it's an indication that they're resorting to that lipolysis. And they will have hyponatremia, low sodium. Compare that to hyperosmolar hyperglycemic state. Again, think about the name. So it is a problem of hyperosmolarity. It's got nothing to do with keto acids. It's got nothing to do with metabolic acidosis. It's purely a problem of high osmolarity in the blood. So because they have high glucose that's not getting into the blood, you have high osmolarity. And this is going to be a gradual insidious onset, as most of type 2 diabetes is, and therefore a slow recovery and poor prognosis. These people tend to be severely dehydrated because of the gradual onset. Remember that when you have high concentration in your blood and therefore high concentration in your filtrate, that's going to draw water out. And they will be peeing out a lot of water over a prolonged period of time, and therefore will be very, very dehydrated. They present with signs that are very different to DKA. So you can get weakness, leg cramps, vision problems, and probably the big one is altered consciousness. They can be very confused and even in a coma. If you measured the serum glucose, it's ridiculously high. 44.4 to 133.2 apparently is typical. And remember, normal is like below 11. So it's pretty ridiculous in HHS. And that's because it's, again, a gradual accumulation over time. It's a gradual buildup, whereas DKA hits suddenly, so it's picked up and treated. In mild, you get hyponatremia because of urinary loss, but in severe, because of the dehydration, you get a relative hypernatremia, high levels of sodium because you have low levels of water.
So there's a question. It goes, will all type 2 diabetics get HHS if not treated/controlled? So I think yes. Assuming their glucose gets that stage and causes all those like kind of physiological symptoms, then yes, it will. But also, I guess it's a progressive thing. Not everyone will have that much insulin insufficiency to the point where insulin resistance to the point where they have like zero control of their blood sugars, basically. But if they're getting all the complications as well, and then they don't use their drugs, and then they get like weeks and weeks and weeks of hyperglycemia, then probably yes, they'll get HHS. But
yeah,
will they always
so if it's
get
very,
it?
very poorly controlled, probably. But remember that you don't have to have pharmacological management. And we'll go over this when we talk about treatment. But type 2 diabetes can be managed just with lifestyle changes. So in that sense, no, because people can manage their diabetes without medication. But if they are not even making lifestyle changes, if the diabetes is just out of control and they're not checking their glucose and their serum glucose is through the roof, then they probably will get hyperosmol or hyperglycemic state. Eventually. Again, it's a gradual thing. The longer term complications of diabetes, it's pretty easy to remember because there's 3 of each. So you have macrovascular complications and microvascular complications. The macrovascular is easy to understand. The underlying mechanism is just hyperlipidemia. Remember, if they're trying to mobilize fats for energy, they're going to have increased fat in the blood. And so you have hyperlipidemia, and that accelerates atherosclerosis. So you just think about, where can atherosclerosis cause problems? It can cause problems in the heart. So cardiovascular disease is a big one, and it's twice as common in diabetics. Coronary artery disease, so where they're building up atherosclerosis in their coronary arteries, eventually getting to the point where you get complete occlusion and an acute myocardial infarction or a heart attack. And over time, if they're having lots of little AMIs, they're going to get congestive heart failure because the muscle will start to fail. You can also have problems in the brain, so they can have cerebrovascular disease. And this can be transient ischemic attacks, which essentially self-resolve after a little bit of time. They might complain of like the vision going for a little bit and then coming back. Or they might have a full-on stroke, and that's 2 to 3 times more common in diabetics, and that can leave them with lasting cognitive impairment. And then the other place is the peripheries. So they can have peripheral vascular disease, which is 5 times more common in diabetics. This typically presents as intermittent claudication. So that's why it's one of the things you ask about in a cardiovascular history. And that's where like they get calf pain when they're walking like up a hill or something. And that calf pain is the exact same as angina. So it's like because they're exercising, their oxygen demand is increasing, but because of the occlusion of the arteries, they can't supply that oxygen. So they get a little bit of sort of ischemia and pain as a result. Over time, that can lead to ulceration, and ulceration, if it becomes infected, can become gangrene and require amputation. So these complications of, whoop, it just went dark. Okay, it's coming back. It's motion detected. These complications of diabetes can be really bad because people who don't control their diabetes well, they tend to have poor health literacy, and they will often not present with these issues until very late. And eventually, like, they come in when they need amputation, and it's like, what can you really do for them at that point? So the complications are quite important to know. You also have microvascular issues, and these are less to do with atherosclerosis and more to do with acute sort of localized vasoconstriction, increased capillary permeability, proliferation of the extracellular matrix, blah, 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 blah. The main thing you have to know is that glucose is essentially harmful to the vessels in high concentrations. And the problems can manifest in the eyes, in the kidneys, and in the nerves. So in the eyes, you can get retinopathy, which is going to be damage to the retina. You can get cataracts, where the lenses become cloudy, or you can get glaucoma, damage to the optic nerve. In the kidneys, diabetes is the leading cause of end-stage renal disease. It's a really important cause of nephropathy that you have to remember. On top of everything else that we learned glomerulonephritis-wise, diabetic nephropathy is the most common cause. It's due to vasoconstriction causing localized infarctions and glomerular destruction, and they basically get progressively worsening proteinuria. So it starts off microalbuminuria, then it becomes gross, which is just bigger, and then eventually full-on kidney failure. Nerves-wise, you get neuropathy, peripheral and autonomic. It can also be like motor, but it tends to be sensory. So they get a classic sock and glove distribution of sensory disturbances, whether that's tingling, numbness, or pain. it happens in the fingers and in the toes peripherally. And that kind of makes sense because it's sort of the longest bits of the nerves that will die first. Autonomic neuropathy is also a big problem, and that can present as urinary retention, erectile dysfunction, gastroparesis, postural hypertension. Just think about all of the autonomic functions that you have. But again, remember that it's going to be the distal things that go first. And that's why it's typically the bladder problems and the erectile problems that actually present first. And remember, in diabetes, people can present with these complications before anything else, especially type 2 diabetes. Okay.
Just to chime in, I want to rehash how important these complications are. Like, there will almost certainly be a question on it, and if you're in the hospital next year, there's almost certainly you'll get asked at some point what these complications are. So if you learn anything from endo, this is the slide to learn. Also, just to kind of clarify points, these things can also happen together. So like for some people, some people think that like if you get retinopathy, you don't get other things. You get them a lot of time together. So if you have retinopathy, you also sometimes will have nephropathy. It's a common combination to have. Also, just a point to microalbuminuria, gross albuminuria, what that sort of like, just double clarify. Microalbuminuria just means like a little bit of amount of albumin in the urine. Gross albuminuria just means a lot of it in the urine. It's not like the size of albumin gets changed. The size of albumin doesn't change. It's just the quantity of it. But yeah, this slide is incredibly important to know. So just to rehash that points.
Yeah. And someone private messaged a question just about why type 1 diabetes is like more acute versus type 2 diabetes. And I think the reasoning for it is because it's an autoimmune destruction. The idea is that once you hit that trigger, once you get the auto antibodies produced, it's sort of an inevitable linear progression, right? It's just going to go straight downhill. Because there's nothing that's really going to stop that autoantibody mediated destruction. In type 2 diabetes, it's because it's such a multifactorial like combination of all sorts of different factors. If a person is living a lifestyle unhealthy, but then also sometimes it's okay, it's very sort of fluctuant. You don't get like that straight linear progression to like crap. It goes it meanders along, eventually getting to a point where they've got that sort of loss. And so it can happen a lot more gradually and a lot more slowly because of that reason.
And if you think with type 1 diabetes, your pancreas sort of compensates for that like lower insulin, lower beta cell population for a very long time. And you only end up with type 1 diabetes because your pancreas fails to compensate. So once that point hits, then you will suddenly get to a hyperglycemic state, and you'll suddenly get with a ketonic breath, and you'll suddenly put DKA as a result of all those kind of physiological presentations. Whereas in type 2 diabetes, it's a lot more of a progressive thing, and you're more likely to get those sort of complications more so than, I guess, hyposmolic hyperglycemic state.
Yeah. HHS is like very late, very bad in type 2 diabetes, whereas DKA is not that uncommon in type 1 diabetes. And that's, yeah, again, it's due to the pancreas's ability to compensate. It can deal with quite a lot before you start to really go downhill. Okay, so hypoglycemia is a complication of diabetes, but on the flip side, it's a complication of overtreatment, really. So it's quite a difficult balance to strike because someone's glucose levels are going to depend very much on what they eat and how much they eat. So a common problem is that people with diabetes will get prescribed insulin or sulphonylureas to try to manage the blood glucose levels, but then they might skip a meal. They might skip breakfast one day, or they might have very little food across the course of a day. And all of a sudden, that insulin that we're giving to try to lower their blood glucose is going to overly lower the blood glucose, and they're going to go into hypoglycemia. So the definition of hypoglycemia varies for males and females. I really have no idea why, but it's a different threshold for each. And once we get hypoglycemia, we try to sort of increase glycogenolysis, right, to try to produce more glucose to kind of mediate what's happening in the blood. And what happens is we release noradrenaline and acetylcholine because those transmitters or hormones, they will help to increase glycogenolysis. They help to mobilize muscle glycogen, they trigger lipolysis, gluconeogenesis, and all of that. So what we get is an autonomic response, activation of the sympathetic nervous system. And this is sort of, it becomes a big problem because after 5 years of diabetes, patients will tend to have quite impaired glucagon responses. So that's the opposite of the insulin response. And so what happens is they struggle to mount this glycogenolysis when they've undereaten. And as a result, they can go into hypoglycemia more easily. And they might also have less symptoms when they're going into hypoglycemia because your autonomic response is not going to get triggered. So hypoglycemia is actually quite a big problem, and education around recognizing it is really, really important for long-term diabetics. The classic symptoms are going to be hunger, obviously, adrenergic symptoms. So think activation of the sympathetic nervous system. They'll sweat, they might have a tremor, they might feel palpitations, they might feel apprehensive or anxious, they might feel cold, not sure about the cold. But essentially they just get very like on edge. And then with progression, they get neuroglycopenic symptoms, which is basically like suppression of the CNS. So they get visual disturbances, things start to go cloudy, they feel vague, they get a bit irritable, they can't concentrate, and eventually it can cause full-on coma, right? The treatment of it, though, is pretty straightforward. You just want to rapidly administer glucose and raise their blood glucose levels. If they're conscious, you can feed them single-dose carbohydrates, whether that's sugar, jelly beans, sugary drinks, and then repeat sort of every 15 minutes as needed. If they're unconscious, you have to do it parenterally. You have to do it for them. So you might do IV dextrose, or you can admit subcut glucagon if IV is unavailable. But IV dextrose would probably be the preferred method. So the treatment makes a lot of sense. It's very easy to remember. And this trio that I've sort of bolded here, blood glucose below, blah, 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 neuroglycopenic symptoms, and responds rapidly to glucose administration, is called Whipple's triad for hypoglycemia. I don't think that's important to know, but it sort of helps you just remember the three big things that define hypoglycemia.
So there's a question that goes, why does glucagon become impaired? So I think this is referring to like after 5 years, blah, blah, blah. I think what that's about, and correct me if I'm wrong, Alina, is that your body is like tried to control that glucose for so long that like any glucose control is just bad at that point. So like even the insulin is not great, the glucagon is not great. And so therefore, when you get to that stage where you need to kind of pump glucagon to give you more blood sugar, it's kind of like, well, I've never needed to do this before in my life. What the heck is going on? And it just doesn't do it properly.
Yeah,
that's how
essentially,
I think about
like, yeah, after a long period of treatment, it's kind of like you've been exogenously controlling your glucose levels for so long, right? Like we're using external hormones, we're using medications to manage the blood glucose level. So that's going to suppress your endogenous control, right? We're going to just get sort of generalized suppression of the pancreas's function. And that's because we are externally controlling. And so suddenly, if you're requiring your body to mount an endogenous response internally, it's like flimsy. It doesn't know how to do anything anymore. All right.
And so the next
this
question
is like
about,
there's more.
And the next question about comas. Is coma present in HONC and hypoglycemic episodes? So HONC being hyper is more like hyperglycemic state. Yeah, I think so. Basically, they both can cause comas.
Yeah, pretty much anything to extremes will cause comas. But yeah, that's like very, very bad. You usually want to stop it before it gets to that stage. These diagrams kind of give you a little bit of a pictorial representation, if you're a visual learner, of hypoglycemia versus hyperglycemia. So the big sort of classical adrenergic symptoms here, where you've got that sort of like rapid heart rate, tremor, anxiousness, sweating, the sympathetic activation. Whereas over here, you've got that extreme thirst and frequent urination, your polydipsia and polyuria, that are very classic for hyperglycemia. You can see the management of hypoglycemia is basically eat something or drink something, whereas hyperglycemia is a bit more complicated. Okay, so now we're going to talk about management. And really, this is kind of like, yeah, 50% of diabetes, I reckon, in second year. It's mostly about knowing the drugs. And the good thing is they're quite conveniently named them. Unlike most of pharm, there is some pattern to the naming, which is always appreciated. So the management of type 1 diabetes is essentially just insulin. Like you can kind of do some lifestyle modifications to try to reduce comorbidities, but they're going to need insulin. They are insulin dependent. And they typically have a basal bolus regimen, which means they're going to have sort of long acting doses whether that's once a day or twice a day, to try to simulate their regular baseline insulin that we have. And then they'll have bolus doses. So before a meal, they'll inject a bolus, which just means a sort of larger dose of a short-acting type of insulin to compensate for the fact that they're about to have a meal and that they're going to need to take all of that glucose from the meal and put it away into the cells, right? So you need to have a basal dose and then a bolus dose with long-acting and short-acting versions of insulin. And then they have to be educated on regular blood glucose testing. So sometimes people will test their blood glucose before a meal and then calculate how much insulin to give themselves during or after the meal based on that level. Type 2 diabetes, there's a little bit more to it. So we start off with lifestyle modifications always. And if that's not going to work, then we start giving them oral anti-hypoglycemics. And there is a whole plethora of drugs for type 2 diabetes. And ultimately, if that doesn't work, then we convert to insulin. Or if we get complete loss as a progression of type 2 diabetes, then we give them insulin. So this is our insulin therapy. We can synthesize insulin using recombinant DNA and administer it via injections. Nowadays, we have fancy technology where they can have like a continuous sort of machine that is just continuously injecting amounts of insulin. So it will measure their blood glucose level and then constantly administer insulin as needed. Really nice, really easy, great quality of life, great control, but it's pretty expensive. So a lot of people still just do like self-administered injections. Compared to endogenous insulin, exogenous insulin is absorbed more slowly and cleared by the kidney instead of the liver. So people who have renal impairment, their insulin doses have to be calculated accordingly. We talked about long-acting, administered 1 to 2 times daily for basal levels, and short-acting, administered before meals to simulate that spike or bolus. Adverse effects, you can kind of imagine if you overdo it with the insulin, you're going to get that hypoglycemia, and people can also have local allergic reactions. It needs to be adjusted for renal impairment and also other things. So if people are exercising lots or eating less, they need to reduce their dose. And if people have stress to the body, so infection, stress, trauma, surgery, anything like that, they might need higher doses. So type 2 diabetes, we start off with lifestyle changes. And this should always be trialed before you give any anti-hypoglycemic. And I remember this was an exam question. It was like, pick the correct medication. And like one person, it was like they'd been newly diagnosed, they had no comorbidities, they were otherwise pretty healthy. What would you give them as first-line treatment? You would do lifestyle changes because chances are they're going to be able to manage without the help of pharmacological therapies. Lifestyle changes include diet, focusing on sort of weight loss. So, you know, your classic diet recommendations, exercise, classic exercise recommendations, but importantly, resistance training improves insulin sensitivity and glycemic control. So you particularly want to recommend resistance training rather than just like walking, which is what most people will do. And smoking cessation is always good. Remember that type 2 diabetes causes a lot of vascular problems, and smoking is also very bad for your blood vessels. So you want to promote vascular health as much as possible because that's probably what will kill a diabetic. Okay, drugs wise, first line therapy, if you only remember one drug for diabetes, it's metformin. Remember metformin, and it's a biguanide. It is the first line treatment unless someone has renal problems, and it should be initiated as soon as lifestyle management is seen to be insufficient. The exact mechanism is not really well known, but we know that it sensitizes the peripheral tissues to insulin basically, and therefore you increase your glucose uptake, decrease hepatic gluconeogenesis, and get all the great effects of insulin. But it doesn't actually have any impact on insulin release. This is supplementing or increasing insulin's action. Adverse effects, kind of vague and non-specific, weight loss, GI problems. It's pretty low risk of hypoglycemia because you're not stimulating insulin release. So you're not likely to overdo it with the insulin because it's just sort of relying on what is endogenously being produced. It can be combined with other drugs, so commonly sulphonylureas or even insulin if it's not enough by itself and it's excreted unchanged by the kidneys. This is your first line therapy. And then if that's not enough, or if there's an issue with the use of metformin, you could add a sulphonylurea. So these ones tend to start with gly. So glicoside, glibenclamide, glipizide. And these, they mimic ATP at potassium channels. So what they do is ATP typically blocks these ligand-gated potassium channels, and sulphonylureas will simulate that and block those potassium channels. That causes depolarization, calcium channel opening, and therefore insulin release. Kind of think about like your action potential type mechanisms. But this also requires you to have functioning beta cells. So it can only really be used early on in diabetes. And there is a risk of hypoglycemia with this one because it's stimulating insulin release. It can cause weight gain apparently, maybe due to the appetite stimulant effect, but not really well known. The whole weight thing, it's kind of hard sometimes with the anti-hypoglycemics. You sort of just have to memorize which ones do and don't cause weight gain. I haven't seen it really super assessed though, so I don't know. It's probably not that important. But this one is often used in combination.
The most important one is just the metformin because it's weight loss, and that's why it's like so good.
Yeah. But this one's often added to metformin if metformin alone is not good enough. If people are allergic to the classic sulphonylureas, they can add glitinides instead. So this is the exact same mechanism of action, but for a shorter duration, and apparently that is just easier on people who have allergies. So these ones end in glinide, repaglinide, nataglinide, exact same mechanism action, but shorter. The next group is these ones, your glitazones. So these all end in glitazone, pioglitazone, rosiglitazone. These are not very good. They have very bad adverse effect profiles, and you really wouldn't use them unless you have no other options, essentially. They work by increasing tissue sensitivity to insulin by binding to nuclear receptor PPAR gamma. This, like the mechanism of action, is pretty important to know because they love it for multiple choice. They'll be like, which of these drugs acts by this? And you just have to remember the buzzword. So PPAR gamma for this one, for example. And that's going to produce transcription of genes that will promote insulin signaling, and therefore you get more insulin action. But on the whole, it's not as good as metformin and sulphonylureas, and it has pretty bad adverse effects. So they tend to get fluid retention, which can cause peripheral edema, weight gain, and importantly, heart failure, because if you have a lot of fluid overload in the system, the heart can't keep up. And so this is actually contraindicated in heart failure. It can also increase fracture risk, anemia, and each of these has their own unique action as well. Rosiglitazone causes cardiac events, and pioglitazone causes bladder cancer. So basically, these are bad. They should not be first line, and they're sort of like a last line choice. Acarbose. So Acarbose is an a-Glucosidase inhibitor, and this one decreases GIT absorption of sucrose and starch. I kind of remember it as like, because it has carb in the name, it's carbohydrates, so it's like your food. I don't know if that makes any sense. But this is going to decrease GI absorption, and it acts by blocking like your intestinal alpha-glucosidase receptors and things like that. Adverse effects, you can imagine if you're not absorbing all of your carbohydrates, they're going to remain in the GI tract. And so people get flatulence, they get cramping, they get diarrhea, but it's not associated with weight gain. In fact, you'd probably have weight loss because of decreased absorption. So this is often useful in obese patients. This is never really used by itself though. This is more so just used as like an adjunct therapy before a meal, because it mainly just functions to decrease absorption of glucose in a meal, but it's not going to do much for like baseline levels and things like that. So they tend to require still metformin and then maybe this on top. Then we start getting into incretin. So the concept of incretin, I think I put it in one of these slides here. It stimulates insulin secretion. It's basically like an endogenous anti-hypoglycemic. So it's great if it can kind of do the job of pharmacological therapies for us if we can try to sort of augment its action. So this is an incretin enhancer. These ones end in gliptin, sitagliptin, vildagliptin, and they inhibit DPP4. Again, that's your buzzword. And that is an enzyme that typically breaks down your incretins. So if we can block it, then we can maintain higher levels of incretin, and therefore that's going to help promote insulin release. Adverse effects, if it's combined with other things, you can get hypoglycemia. And then there's all sorts of like random weird things, MSK pain, upper respiratory tract infections, pancreatitis, headache. Don't really know the underlying mechanism for these guys. They're very random and weird.
I think the pancreatitis is important because if you're almost overstimulating your pancreas, you can get, that's why it causes that inflammation. So I think
that makes
pancreatitis
sense.
is probably the most important one there.
Yeah, that makes sense actually. Yeah. So pancreatitis because you're overstimulating. This is used often in combination with metformin or sulphonylurea if each one is not good by itself and the combination of the two is contraindicated. But usually when it comes to increasing pharmacological options, we tend to go for metformin first line and then add a sulphonylurea. These other ones are kind of all just like extra options if any of those things is contraindicated. The long-term safety of this is not that well known because it's still a relatively new drug. And then we also have incretin mimetics. So enhancers are going to stop the breakdown of incretin and therefore enhance their function. Incretin mimetics are going to mimic incretin. So these are GLP-1 analogs, or there's really only one main one, and that's exenatide. And it basically mimics incretin. So it stimulates the insulin secretion, slows gastric emptying the way that incretin would. Lots and lots of adverse effects again, and it's typically again used in combination with other medications when they're insufficient by themselves. This one is administered as an injection. Gliflozin. So this is your reabsorption inhibitor. So these ones are the ones that cause UTIs. And that's because their mechanism of action is inhibiting glucose reabsorption in the PCT of nephrons. So it's going to increase the amount of glucose in your pee. The idea is that if you can pee it all out, then it won't be in your blood. So that's great. But the problem is that if you have lots and lots of glucose in your blood, then that's also going to help promote bacterial growth because they'll have lots and lots of food in the urinary tract to grow and thrive. So vaginal candidiasis, which is like a fungal infection, or UTIs in general, are increased with the use of these drugs. And actually, they've been trialed in heart failure because you can imagine if you're pulling out glucose, lots and lots of glucose, that's also going to pull out lots and lots of water because of, osmolarity. And that can actually have a diuretic effect. So when we were talking about diuretics before this in renal, Kevin, I think, mentioned the use of SGLT2 inhibitors as a diuretic. It's primarily an anti-diabetic drug, but it does have a diuretic effect because it's going to increase the osmolarity of your urine and therefore pull out water. This one can cause hypoglycemia as well with your sulphonylureas or your insulin. And that's because it's going to actively sort of pull glucose out of the blood. And so if you're not eating to constantly replenish it, they can very easily become hypoglycemic. Okay, and then we'll finish off with a bit of clin skills type stuff. So diabetes history. This one, everyone glossed over. No one bothered to learn. And then guess what? It popped up in our OSCE and everyone was stumped, me included. They were like, take a diabetes history. And I was like, do you have diabetes? Didn't really know what to ask. So this is a diabetes history. You might think it's not important, but it can come up. So the things you want to look at are how well they control their diabetes. So this can be things like, do they check their blood glucose? What was their last reading? And have they had a HbA1c done? What was that? Because that, remember, is going to indicate your longer term control. You can ask about symptoms, whether they've had recent onset of symptoms or improvement of symptoms. You can ask about hypoglycemic episodes and hospital presentations, also as indications of how well they manage and control their glycemic range. You can also ask about lifestyle risk factors, so sort of evaluating their risk of like complications and how well they're sort of, or I guess how reliant they are on pharmacological therapies. So things like smoking, nutrition, alcohol, physical activity, really just things that are always good to ask about. And that's your SNAP mnemonic. And then you want to ask about medications. So what medications are they on? How compliant are they with it? Because some will admit that they don't take it ever. And then it's like, well, what's the use? Side effects, because side effect profile is important and there are many options. So if someone is experiencing bad side effects, you can switch to a different version. And changes. So if they've recently added a new medication, That's important to know about as well. And then you want to assess for complications. So for this, you just think about what those 6 complications are and a classic question for each one. So vision changes for retinopathy, urine changes for nephropathy, particularly they'll have frothy urine if it's proteinuria, changes in sensation if they have neuropathy, intermittent claudication as that peripheral vascular disease, chest pain as that cardiovascular disease, and TIAs or strokes for cerebrovascular disease. And remember, TIAs can be like, they self-resolve, whereas strokes don't. And it can be things like hemiparesis, so loss of movement in one side of the body, or it can be like a vision impairment, things like that. And then you can also ask about other conditions that are associated with diabetes. I don't really know why this one is too important, because obviously they've already been diagnosed. So you're not really looking for risk factors anymore. But in type 1, you can ask about other autoimmune conditions. It's really just a flex of your knowledge, like that you know that type 1 diabetes is associated with other autoimmune conditions. So you can be like, do you have any thyroid problems? And then type 2 diabetes will be associated with PCOS, gestational diabetes. That's more of a history thing. And then cardiovascular problems. So again, that's sort of like a flex of your knowledge.
So we've had a question that asks when you would ask these questions. So just in terms of a practical thing, in terms of how we were asked to take diabetes history, it was like the most messiest thing ever, because the marks weren't even for a diabetes history. But so it's kind of like annoying. But I think this would just replace a systems review, kind of. It depends on sort of what the STEM sort of is. So if they ask you to kind of just talk to them about the diabetes and they don't have a presenting complaint, then this is kind of all you'd ask them, and you wouldn't do WWQQA. But I think that's kind of harsh for a second year, and they don't really do that. So they'll give you something that's a presenting complaint, maybe they had a UTI or something, which I think what we had. And then you just tie in the diabetes history at some point. But yeah, it comes with your systems review sort of stage, I think. But it's also kind of just where you see fit a little bit. The history is a little bit of your art. Like, it's how you just ask questions.
Often they might be real low key about it. Like, they won't even say like it's a diabetes. It might be like, this person came in with a symptom and they have a history of diabetes. And like, you won't even look at the diabetes part. You'll like gloss over it. And it can often come up in your like past medical history. So what I like to do personally is when they say, oh, I have diabetes, you ask them like, how is it being controlled? How is all that? And like, have you had any changes? Have you noticed anything unusual there? So yeah, it varies between person to person, and it can really come up anywhere. So yeah.
Even if they don't ask you to take a diabetes history, if they present and they say in a past medical history, oh, I have diabetes, I always ask what their complications, or if they have any of the complications, such as like, like nephropathy or retinopathy, anything like that, just because it assesses their like progression or how far they've gone and their control with it, anything like that.
Yeah, and do whatever feels natural as well. If the patient starts talking about, oh, I have diabetes and it gives me this and I'm on this drug for it, then just kind of move into, you can say like, oh, are you taking any other medications, for example? Or when you're doing the lifestyle factors, because you're going to go over your smoking, your nutrition anyway, then you don't necessarily have to pair that with your diabetes. So be fluid. As long as you kind of hit everything, it doesn't really matter. Sometimes just going with the flow and making it sound natural is more important than saying, okay, I'm going to go through the past medical history and then the drugs and then everything else, because that can confuse the patient a little bit.
And I think in the OSCE setting, again, it depends a lot on what scenario they give you. So if it just says diabetes history and nothing else, no presenting complaint, then you really want to focus on this and like go through every single question. If they come in with a presenting complaint, so our one, it was some kind of urinary change. So they had a urinary change and they had a history of diabetes. And then it was like, do a diabetes history. So you actually, like, I passed mostly on doing a urinary history, like with systems review. So as long as you sort of, if it's a presenting complaint, you still do your WWQQAA, whatever, you do your systems review for that system briefly. And then you just want to throw in some diabetes stuff to show the assessor that you know what you're looking for. So when they mention their past medical history and they say they have diabetes, you'll ask them about their control. When you do your social history, you'll ask about your lifestyle factors. When you do medications history and they say, oh, I'm on metformin, then you'll ask about compliance and side effects and changes. And then when you're doing sort of systems review, that's when I would throw in complications. So it does kind of integrate with the full history start to front, right? Start to end. not start to run. And so you kind of just want to touch on each of these things as you go. Like JJ said, it's sort of, it will feel kind of natural because they'll mention the drug and then you'll be like, oh, so are you good at taking it on time and things like that? Or they'll mention that they've experienced some kind of complication and then you'll ask about other complications. So it does kind of integrate with the full history.
One thing I would say that even if they don't say they have complications, ask specifically for the complications.
You want to show that you know the complications because it's highly accessible. Yeah. Diabetes exam. Not going to read through the whole thing because it's not particularly exciting. It's kind of a combination of like a peripheral neuro exam and then also like a bit of cardio and a bit of derm. It's very random. But the main things are like you want to comment on like signs of Cushing's and acromegaly because that's associated with diabetes. Hemochromatosis, bronzing of the skin, also associated with diabetes. And acanthosis nigricans because that's that big sort of buzzword, but you're probably not going to see it. I was taught by my clin skills tutor to start with the legs in the diabetes exam, which is counterintuitive because we normally always do legs last, but that's because legs is probably the highest yield part of the diabetes exam. It's mainly about your sort of peripheral neuropathy. So I was taught to start here and then move to the rest of the body because this is where most of the marks will be. You want to look for necrobiosis, which is kind of like a waxy sort of look, ulcers, hair loss, color changes, fungal infections, muscle wasting, deformity. A type of that is Charcot's foot. And then you sort of want to assess. So I think like you want to assess the vessels and you want to assess the nerves. So you want to look for temperature, if there's good capillary refill, if you can feel the pulses. And then for the nerves, you want to be looking at how are the reflexes and can they feel vibration, pressure, blah, 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 blah. All of that sort of stuff, your normal peripheral neuro exam. And that's because vessels and nerves are the first things to sort of go in diabetes, right? You get your neuropathy and you get all of that peripheral atherosclerosis. And then other things that you're sort of looking for in the hands, tissue turgor and cap refill are going to indicate again how patent the vessels are and also hydration status. There's some eye stuff that you kind of mentioned, but I highly doubt you'll be asked to whip out a fundoscope in your OSCE for this. But then you also take a look in the mouth for thrush because fungal infections again are common, and that ketotic breath you would comment on as a sign of like DKA. Assess the vessels in the neck as well and hydration with the JVP. You assess for fluid overload by having a listen in the lungs, feel the apex beat for if it's heaving, and that might indicate heart failure again from fluid overload. And the abdomen, you would look at injection sites for fat hypertrophy or atrophy, which can happen where they're injecting insulin. And you might also palpate or percuss the liver. The diabetes exam feels really kind of all over the place, and it's kind of a tricky one to learn because it is like a little bit of everything, and it kind of combines a whole lot of different systems. But they can very much ask you to do a diabetes exam. I would probably maybe check with Nadita because it was actually a contentious thing last year. Some people were like, Nadita said we won't get a diabetes exam. So I don't know, maybe check because it was contentious.
I think I remember asking Nadita like whether we'll get a diabetes history, and she's like, "What's a diabetes history?" And then look what happened.
And then guess what? It popped up. Yeah, sneaky. The last thing is an explanation station. So you might not have done much on explanation so far, but there are a couple things, and it can come up in OSCE where instead of doing a history or exam, you're asked to explain something to a patient. You can be asked to explain urinalysis in renal, but more likely they just ask you to perform it. Glucometer use, however, is a common explanation station. I think it was in our practice OSCE. So these are sort of the steps that you want to go through, and it's easiest if you like can get your hands on one, and they'll do that when you go in for clin skills, I guess, to actually fiddle with. But the steps include you want to wash and dry your hands before performing the test because you don't want to get like dirt on the strip or water on the strip. It will come with the strips in a little bottle, and you again have to check the use by date for everything. So just like with urinalysis, you check the expiration date on that. You want to check the expiration date on your little strips here. There can be a calibrator strip in the machine to check if the machine is accurate, but I don't think you use that every time. And so you want to pull out a test strip from the container, close the cap so that it doesn't spill everywhere, as with all caps. And then you put the test strip into the machine with the little metally bits pointing inwards. So it's, you know, communicating with the machine. I don't know, technology. And then the meter will sort of detect the presence of the strip, and it will beep when it's ready. And you'll see like a little symbol that looks like a drop of blood, and that's indicating that it's time to put your blood in. So there's a lancing device, and these ones, again, you want to either be able to get your hands on some or just have a look at some pictures, because they can be kind of weird and confusing. But you can either get single use like needles, which are kind of frightening, or like the jabby pen ones. And the most important recommendation is that they jab the side of the finger, not the pulp here. Because here it might feel soft and squishy, but it's very, very sensitive and very, very painful. Whereas the side is going to be a lot less painful to jab. So you would hold the pen to the side of the finger, push down to prick, and then you can sort of slowly massage up the finger to try to stimulate blood flow if there's not much blood coming out. And then you hold that to the machine, to the meter, to this little sort of bit that's sticking out here. That's where you hold the fingertip to. And you don't need to like wipe or drip the blood on or anything. It sort of like suctions the blood up. So if you just hold the drop of blood near it, it will suck it up. And then the meter will start to sort of process it, and you see like a little hourglass as it's doing its thing, and eventually it will flash the result on the display. It's important to know what the normal ranges are, because if they do an explanation station for glucometer use, they will probably want you to explain to the patient what they should expect to see, and maybe even what they should do if it's weird. So like you might say, if it's too low, if it's below this range, then maybe have a snack. Or if it's too high, if it's above this range, maybe call a doctor, something like that. And general explanation station tips, I guess, because we haven't really talked much about it before. You always want to start off by asking how much the patient already knows. So you might be like, have you ever used a glucometer before? Have you ever seen a glucometer? Seen anyone using one before? Do you know what it does? Things like that. You want to assess how much how much they do know, and then you want to ask, is there anything in particular they want to know? So, you know, is there anything that you're particularly confused about that you want to know? And then you go into your explanation. And as you're explaining, you don't want to give them this whole 11 steps in one go without stopping. That's not very good patient rapport. So you might give them a couple steps, see if they understand. You might ask them to repeat it back to you as a way of assessing understanding. A common one for glucometer, because you'll actually have it, is you explain and then you give them the glucometer and ask them to show you how they would use it, and you can assess their retention that way. And then at the end, people love to like offer some extra resources. So they might be like, here is a brochure, and hand a fake brochure, or they might be like, you can go to this website and some like Diabetes Australia or something for more information. Things like that, to show that you're really trying to like facilitate the patient's understanding. If you do all of that, you're probably going to score pretty fine for an explanation station. If it's not glucometer, because glucometer is nice and easy, because you'll probably have it physically in the room. But if it's something like explaining contraceptive use, which we'll talk about in Repo and XM, you can also like draw diagrams and stuff. There's bonus points for that, because it again just helps increase the patient's understanding. And that is it for diabetes. So any other questions? I'll stop sharing my screen. Aw, thanks, PSPanda. Look, so here's the thing. I do also have some slides on HPEBM, kind of summarizing your semester of HPEBM, but I don't know how much you guys want to hear of it. If you guys are not really keen to hear it, we can just post the slides. Or if you want, we can quickly go through it. Does anyone have any particular feelings either way?
You can PM what you want if you don't want to make a decision on behalf of the group.
Yeah, feel free to PM to either of us or any one of us. I've tried to keep it high yield because obviously HPBM will go on forever. Can we quickly go through it, says KZ. Have we got any other input from anyone else? If not, we will just go through it based on the one vote.
There are like a fair amount of marks in the exam on HPBM.
It is actually pretty important. It tends to be the short answer. Someone has also said post slides. I suppose if you don't really want to hear it, you can just leave, to be honest, because that's it for endocrine for today. So we're just going to talk quickly about HPBM after this, and then you can join us on Sunday for thyroid, parathyroid. What else have we got? Adrenals, yeah. The rest of your endocrine stuff, okay? All right, otherwise I'll just go ahead and quickly go through this. So let me share my screen again. All right, so I'm gonna keep it pretty brief because there's really a few key points to know, and then the rest of it's not that important. So this you may recognize from first year, both semesters of first year, because it's absolutely hammered in. So the definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. There is this Ottawa Charter requirements for health, these 8 things. They can ask you to essentially recall a couple. They're not going to ask you for all 8, but they might be like, list a couple. So peace, shelter, education, food, income. It's pretty logical if you sort of think about it. But the main thing is you'll see that like healthcare is not a thing here. It's more to do with the environment and what's sort of around them facilitating health, not so much like direct healthcare, but you can kind of make them up as you go. Social determinants, again, you will recognize they are the conditions in which people are born, grow, live, work, and age, including the health system. They're shaped by all sorts of things, and they're very important because they are essentially the upstream factors that contribute to poor health down the line. So people who are in lower socioeconomic statuses, we know tend to have poorer health. People who are unemployed, we know tend to have poorer health, things like that. Social determinants contribute a lot to how, I guess, a person's baseline level of health. Health promotion, these 5 action areas are really important again because they love to ask short answer questions on it. And it is essentially sort of the 5 ways that we can promote health in the community. So you can build healthy public policy. So that can be like making smoking illegal in certain areas. You can create supportive environments. So that can be like building public parks with exercise equipment to promote exercise. You can strengthen community action. So that can be like having like community exercise groups and things like that. You can develop personal skills, and that's teaching people how to exercise well, or giving people the skills to quit smoking. And you can reorient health services, which is kind of a bit of a weird one, but it's this idea that you can, instead of focusing on treatment, you can focus on prevention. Or you can move health services, instead of like people come to you as a GP, you can actively offer health services in the community to try to promote the uptake, essentially. Just be able to create a couple examples of these for any particular public health issue. So how might you promote health for, say, COVID-19 prevention? You can build healthy public policy by enforcing social distancing, things like that, right? Health promotion is important because it's prevention, and prevention is much more cost effective than treatment. Then they use the examples of obesity and road toll. There's not too much to know here, and again, you probably already know it as common sense. Here are some stats. Upstream factors can include all sorts of things, but again, they kind of make sense. Culture is actually an important one. Certain cultures, there's sort of diet changes, exercise changes that contribute to obesity. Socioeconomic status is obviously very important. And then your midstream factors are sort of a person's decisions and behaviors that contribute to their health, versus upstream, which is kind of like their environment, a bit out of their control. So this is your step. And then downstream factors are health things that are associated with obesity. So if a person has diabetes, if a person has cardiovascular disease, depression is actually a big one for obesity, that can also contribute. Obesity is a big problem because of diet, essentially. we consume very little of our energy, 35% of our energy from discretionary foods. So quite a bit of it from foods that we don't really, I guess, get a lot of nutritional benefit from. And we consume way more sugar than we should. So half of Australians consume more than the recommended amount. The average consumption is 60 grams and the recommended is less than 50. We eat out too much, on average 2.5 times a week. And we have sort of larger portion sizes when we eat out too. Limitations on progress. This is not that important. It's kind of wishy-washy. But there is this issue of personal versus collective responsibility. There's sort of a lot of like blame on people who are obese as like they are personally responsible for it. But we have to remember there's a lot of upstream factors that contribute, and tackling those can be just as important as tackling personal decisions. The other thing is that a multifaceted integrated approach is really important. And that's just thinking about the action areas. So you can't just tackle obesity by, telling someone to diet. You need to improve their exercise. You need to improve their motivation, things like that. And a community-based approach will be more motivating than just like personally telling one person to do one thing, right? If you can have them join a community exercise group, they will be much more inclined to actually exercise than if they're just told to go exercise by themselves.
Just a chime in, we have a question that goes, is this taught in SEM 2? Just to address, I guess, that we got taught this in SEM 1. I look at my notes quickly, and this is all like SEM 1 stuff. If, I guess, this hasn't been taught to you in a lecture or a lectorial, as HPEM likes to do it, then don't stress about it too much. But this is kind of what we had, and I imagine, I don't think they change it that much year to year. But if it is a lot, if it is a lot different, let us know though.
The obesity and road toll thing might be like a case example that they sort of gave to us, and it might be different for you guys. But probably the most important things to remember are like the frameworks, is they tend to be the things that they ask you about. So like your 5 health promotion action areas, they're much more likely to ask you about. Your Ottawa Charter, 8 things they're much more likely to ask you about, versus like random obesity facts. In an exam, that's much less likely to come up. So remember your frameworks, remember like the key like things where there's like a set outline. You want to learn that sort of stuff.
The framework is also much more high yield. Like a lot of the nitty gritty random stuff for like the diabetes or the obesity, and the road toll, you can almost like common sense it.
Yeah, a lot of it you can make up if they ask you about it in short answer. But the frameworks you have to know. If they ask you about like how you can approach health promotion, you do have to know the specific worded like literally the exact wording of these things. If you can say build healthy public policy, you get the mark like straight away.
They haven't done any health promotion. They just did EBM, evidence-based medicine.
Okay.
So, do you want to maybe go to like the bits we talk about, like med literature? Because
EBM is separate. Yeah. So you can have a read through that for interest if you want. Then evidence-based medicine. So there's, I guess this cuts it even shorter, which is nice. These are the 3 things that you have to remember for evidence-based medicine, the 3 pillars of evidence-based medicine. Oh my God, it just went dark again. It's fine, I'll just present in the dark. It's a combination of best available evidence, clinical expertise, and the patient values and preferences. Basically, the general literature, the physician, and the patient. Those are the 3 things that you have to consider in evidence-based medicine. So best available evidence is obviously going to be, your medical literature, your systematic reviews, your RCTs, all of that fun stuff. Clinical expertise will depend on the clinician and their experience. And then patient values and preferences will differ patient to patient. And you should never assume a patient's values to be the same as a clinician's values. They can be very different. Barriers to EBM. Basically, they rant on and on about this as like there's a lot of bias. And the big one is publication bias. If a study finds a significant positive result, it is much, much more likely to get published. Whereas if a study finds no result or a very minor result, it's much less likely to get published. So this obviously skews the entirety of medical literature towards what actually has produced positive results, and not so much showing us the negative results that might have happened from the same exact drug, for example. And that can skew our perception of a drug as much more effective than it actually is. But in reality, it's just because we're much more interested in publishing significant results. That's really the main thing to know. There's other kinds of biases here. An important one to know is Tower of Babel bias, because you can't guess it. And that's referring to the fact that journals written in English and studies written in English will tend to be published in big English journals versus, say, German, which will be published in German journals and things like that. The other ones you can kind of guess, so we won't worry about those too much. The 5 A's in EBM, this is important because, again, they love asking about frameworks, and this is a framework. So when we're applying EBM, you want to start by asking an answerable question. And for this, you've got to remember PICO/PICOT. So PICO stands for patient/population, intervention, comparator/control, outcome, and then T is also like type of study. So for example, if you're thinking about a particular treatment, say for example, let's say aspirin, because it's a popular classic example, the question, the PICO question, might be like, in patients with a past history of cardiovascular disease, that would be your patient, does the use of aspirin, your intervention, compared to placebo, your comparator, improve or decrease cardiovascular related mortality, your outcome? Okay, so if you can ask an answerable question that hits each of those 4 points, then that's the ask part of it. So they can do multiple choice questions, which they tend to do, where they'll list out a bunch of questions and they'll ask like, which one is a PICO question. So you just want to make sure it ticks off each of those 4 things. It tends to just be the longest answer. The next A is access. So you want to access the best evidence. And the important thing to know here is how to search the medical literature, which is something they rant on and on about, but I didn't really properly learn until this year. But the important thing for you to know is how to use the Boolean operators, because they love this in multiple choice questions. So or means that you will, it will show any search results that have either of the terms. So like ticagrelor or clopidogrel. You probably don't know those drugs, but like you will accept either of them. Whereas and it's like you require both. So for that previous question, I would say like cardiovascular disease and aspirin, because I want both of those things to be present in the results. I don't care about aspirin use for like, I don't know, leg pain or something. I don't know. Or like use of other drugs in cardiovascular disease. I want cardiovascular disease and aspirin. But I might say cardiovascular disease or coronary artery disease, right? And in that case, I would accept either of those terms because they kind of mean the same thing. So you use or for synonyms, and then you use and for things that you want together. And then not obviously means excluding certain results. So maybe I like don't want children. So I'll be like not children, things like that. Truncation is important to know as well. So you use an asterisk or a dollar sign to basically try to capture different variations of a word. So pregnan with an asterisk will include searches that have pregnancy or pregnant. This is really good for when you have like ing endings to things or ed endings to things, and you want to include all of them. You just use a truncation. So the multiple choice questions they tend to ask for this are like, which of these has correctly or incorrectly used Boolean operators? And you just want to make sure that they're only using or for synonyms, they're using and between all of the separate criteria for their search, they're using not incorrectly, correctly, and they haven't truncated inappropriately. You can also limit publication year if you want particular recent studies, but that's more of an applicable thing than an examinable thing. Once you have accessed all of the literature that is relevant to your question, you want to appraise the literature, you want to apply it to the patient, and then going down the line, you want to assess its applicability and effectiveness for that particular patient. They're your 5 steps for applying evidence-based medicine to a particular patient's case.
Just on the previous slide, one about biases, for the Tower of Babel bias, if you can't remember it, I feel like knowing this, what the Tower of Babel means, is actually helpful. Because it's like a story about them building a tower to God because they're trying to reach heaven, and then God tries to stop them all working together, so he makes them all like speak different languages because they can't communicate. That's why it's all about things being in different languages, if that helps.
That's
Just
fascinating.
a fun fact.
I never knew that. Cool. Yeah, that would probably help to understand. Critical appraisal. So this becomes more of a thing next year because you actually have to like do critical appraisal. This year, you kind of just have to know what it is and what it entails. So it's sort of looking at how much you can trust a journal article. So there are a couple different measures, or well, many different measures of journal impact, article impact, and author impact. I wouldn't bother memorizing these things, but just sort of have a rough idea in your mind where you'd be able to sort of recognize what it is. So journal impact factor, the number of times an article has been published in the previous 2 years. Published in the previous 2 years has been cited. So if a lot of people are citing a particular journal article, that means they're all using it in like other publications and things like that. And that means it's probably more reliable, but also it's probably just a bigger, like it's a more significant impact. Rank. So apparently journal articles get ranked, I don't know, a certain amount of prestige associated with a higher rank. There are also quartiles that go along with that. So it can be in Q1, the upper 25%, or Q4, the lower 25%. And also you can just have a look at the raw citation number, which is unreliable according to EDM people, but also very easy to do. So if you're on like Google Scholar, it's very easy to just pick the article that has the most citations because it's probably going to be useful. But that's not the best answer because it's not as technical as the others. In terms of indicators of article impact, again, you can look at citation count. You can look at field weighted citation impact, percentile benchmark, outputs and top percentiles. Look, I wouldn't know how to look for any of these things, so I wouldn't stress too much about it. And then author impact, it's like their cumulative number of publications, their cumulative number of citations, and that's going to tell you how involved a person is in the particular field, and also, I guess, the amount of expertise that they have. Because obviously, if a person has been studying a particular topic for many, many years and has published like 20 journal articles on the topic, they're going to be a very trustworthy source of information. Identifying bias in results. So there's a lot of potential sources of bias. These are probably the most important ones that you have to be able to like identify / I guess suggest in an exam. And that can include the inappropriate influence of funders. So if you have a drug company funding a drug study, as is often the case, if that company produces that drug, that might sway you in how much you trust the study because there can be inappropriate influence there. Contamination, that's sort of just relating to if the study design is poorly done. Baseline imbalance. So if we're trying to compare a study or an intervention group with a placebo group, but let's say the intervention group starts off with much milder disease than the placebo group, then obviously you're going to see like a better outcome in that group, right? So they need to have sort of baseline similar levels in the two populations. Crossover trials and washout periods. So that's like if you have one population doing placebo and then the trialed drug together, you need to have an adequate washout period because otherwise maybe the effects of the first one are flowing into the second period and then you incorrectly attribute it to the second intervention when actually it came from the first intervention. Double publications, this is again just like a technical thing that they love to complain about, but basically people will publish their results like halfway through the trial and then publish them again at the end. And so it's like it's been published twice when in actual fact it's just the one study. So it makes it seem like a lot more impact than there actually is. Incomplete outcome data, so if a lot of people drop out of a study, then it's much less trustworthy, the results, because you have to inquire about why they dropped out. Maybe they dropped out because of adverse effects that are not being reported. And so that would also sway your amount of trust in a particular study. Selective outcome reporting, and this is again relating to adverse effects. So people might be like, wow, this drug is so great, it has such great effect, but not comment on the adverse effects. And a really good example of this is anticoagulants. The idea is that the more anticoagulant you give, yes, the less clotting that patient outcome will have, but the adverse risks are higher because the person can have bleeding events. So you can give a massive dose of warfarin, anticoagulation, and be like, wow, look, this person never had a clotting event for the rest of their life, and then not comment on the fact that they died from hemorrhage preliminarily. So things like that can definitely skew the perception of results as well, and that's all sources of bias. Some of the best ways of reducing bias are basically randomization and blinding. If you randomize people, you're much less likely to have imbalance at baseline. If you blind and you conceal allocation, then people are less likely to skew the results on a sort of personal level, and that's called performance bias. Evaluating significance. So statistical significance is based on the p-value, and we usually use a value of less than 0.05. So if the p-value is reported to be less than that, then we reject the null hypothesis and accept the alternative hypothesis. It is really important to know the difference between type 1 and type 2 error, because it's very easy to confuse and also very easy to examine. Type 1 error is a false positive, so incorrectly rejecting the null hypothesis. Type 2 error is a false negative, failing to reject the null hypothesis. These are some of the stats that you might remember from biostatistics last year. Yes, they come back to haunt you forever and always. Absolute risk reduction is basically the difference in the percentage of risk in the two populations. Number needed to treat is 1 divided by that. Relative risk is like the ratio of the risks, so dividing. And then relative risk reduction is the difference divided by the risk in the control group. Just refresh your knowledge of these stats because they always seem to come back. And then when it comes to evaluating how precise a result is, you need to look at the 95% confidence interval. And most importantly, you want to see if that confidence interval includes 1. If it does, then the result is not significant. So if something has a very high, I guess a very big result, whether it's positive or negative, but the confidence interval is super wide and crosses neutral, then it doesn't matter how significant the result is, it's not statistically significant because the confidence interval crosses 1. So that's your real big test there, alongside the p-value. Factors that affect generalizability, you can just have a read of this, but basically sometimes you have a statistically significant result that is not going to be clinically significant. Maybe they tested too niche a population, so they specifically tested like one particular racial group of a particular age with a very particular level of disease, and that's obviously not going to be generalizable to the rest of the population. Or let's say they did an unrealistic amount of intervention. So they force people to exercise for 2 hours a day. Of course, you're going to get a nice result from that, but it's not going to be clinically that significant or clinically applicable because no one is going to exercise for 2 hours a day if you just tell them to lose weight that way, right? So things like that can affect how generalizable a study is, regardless of how significant the actual results are. Oops. Validity, reliability, applicability. Just things that we assess for how good a study is. So validity is separated into external and internal. External is that idea of how applicable is this result. Does it answer an appropriate question? Is it generalizable? Whereas internal validity is like, has this study design actually been designed adequately to answer the question? And that's sort of relating to bias. So if you're trying to answer a question, but the study results are very, very biased, then you're obviously not going to have a very valid result. Reliability is sort of to do with reproducibility. That's how I think of it. And it's the idea that like if someone was to repeat this study 10 times, would they get the same sort of results? So it's about consistency of a result. And then applicability, we've already talked about. And one of the other considerations for applicability is cost. If a drug is very, very effective, but it costs like $20,000 a dose, it's not going to be very realistic as a treatment for people, for the general public. What else do we have? And then we get into our types of studies. So systematic reviews are up the top. And that's because they synthesize and appraise a variety of primary research papers, and you have to clearly document the methodology. This is something that I didn't know. So when they are conducting the search and I guess deciding what articles to include in a systematic review, that has to be a clearly documented process so that someone could theoretically pick up that process and produce the exact same systematic review. And the idea is that that should reduce any bias, right? So you have to have very clear documentation. Here's the procedure for a systematic review, basically common sense. Advantages and disadvantages. This is very wordy and also very common sensey, but you can sort of have a read of it. The advantage is essentially that it condenses a whole lot of studies into one simple, straightforward, objective answer for a particular question, right? So it takes all of these different studies and it puts it into one clear answer. And it's reproducible. If a new study gets added, then you can just apply the same search criteria and amend that systematic review or update that systematic review. Disadvantages, basically sometimes by trying to find the total average result, you overlook individual significant results. So you can, different systematic reviews might disagree with each other. There might be inappropriate sort of weighting of different sized trials. You might ignore a very well done large clinical trial just because a different smaller clinical trial or several different smaller clinical trials showed different effects. So it can inappropriately, I guess, overlook one particular study in favor of the overall average, which might be a bad thing, it might be a good thing, kind of hard to say. Meta-analysis. The difference between meta-analysis and systematic review is that meta-analysis is like a subset of systematic review. And this is basically when you combine the analysis of many different studies. So many, but not all, systematic reviews will contain a meta-analysis. Threats to validity, these are your biases. These are probably the most important biases to know that I would think of. Selection bias, and this is when you're picking your population out, cherry picking to suit your outcome. And the best way to get rid of that is randomization. Information bias is like measurement errors, misclassification, not a lot you can do there. Confounding is if there's other variables present that could be affecting, and that's to do with, like, again, if your populations are different at baseline, and it can be counteracted again by randomization. And there's chance. If I guess if you repeat a study enough times, you will always by chance find a positive or negative association. The important thing to know with this is how to interpret and understand a forest plot, because they can very much just give you a forest plot and ask you to, I guess, give you a series of multiple choice options interpreting it. Of all of the things in the forest plot, the most important thing to look at is the diamond at the bottom. The diamond is the aggregate average effect of all of these studies that have been included in the systematic review. So it averages out the odds ratio. And so wherever it sits, whether it's on the negative or positive side, that would be sort of your overall conclusion of if there was a negative or positive effect. And importantly, its sort of horizontal length indicates something of like a confidence interval. And so if the diamond is crossing 1, you're going to have no effect. If the diamond is not crossing 1, then you have a statistically significant effect. An odds ratio along the bottom, an odds ratio of 1 or a relative risk of 1 means no change. Then along here, you would have all of your studies individually listed, typically in alphabetical order, with a square. And the square position indicates what that odds ratio was in the study, and the square size typically indicates the size of the study sample, right? So if you have a big square, then that's going to be, I guess you're going to consider this much more than something that is a very, very tiny square, which might be a tiny sample size. But on the whole, when it comes to interpreting forest plots, the diamond is the most important. The last thing is a funnel plot. And the funnel plot idea is just to sort of illustrate if there is publication bias or not. The idea is that if you plot all of your studies along an x-axis for the effect size from negative to positive and the y-axis of sample size, you would expect as your sample size increases, the effect size decreases. It's like a normal distribution, okay? It sort of comes towards the middle, whereas when you have a very small sample size, it's much easier to produce a large effect, whether that's positive or negative. We would usually expect to see sort of an isosceles triangle, where you've got all of these guys up in the middle with their high sample size, and then low or small sample size on either side. But if you've got skewing of the funnel plot, like here, that tends to indicate publication bias, and the funnel will typically be skewed towards the side favoring the intervention. And remember, that's the idea that pharmacological companies tend to fund drug trials. And so they would much rather publish studies that find a big positive effect for their drug than any study that finds like a negative effect. So these guys tend to disappear and you get this skewed shape, and that just shows that there's publication bias. Likelihood ratios. So this one is actually very, very important. Probably should have put it near the beginning, but that's okay. You have to know how to calculate positive and negative likelihood ratios and also how to use them. So a positive likelihood ratio is sensitivity divided by 1 minus specificity, and negative is 1 minus sensitivity divided by specificity. Very confusing, but very important to know. And all tests will have an intrinsic positive likelihood ratio and a negative likelihood ratio. In terms of using it, this is the rule. So if we think a specific diagnosis is likely and we want to rule it in, you want to pick the highest positive likelihood ratio. If you think a diagnosis is unlikely and you want to rule it out, you want to pick the smallest negative likelihood ratio. So when we use it, we start off with our pre-test probability on the side here. In the middle, we have our likelihood ratios from smallest to largest. And on the side here, we have our post-test probability. And you basically draw a straight line from your pre-test through your likelihood ratio, and that will take you to your post-test probability. So it makes sense that no matter where you start, you want to go through a high likelihood ratio, positive, because that's going to give you a much higher post-test probability. That's essentially going to rule in a diagnosis. If you're trying to rule something out, you want to have a small negative likelihood ratio so that you end up with a very low post-test probability and you essentially can rule out a diagnosis. The last slide here is just about clinical practice guidelines. This is not so important, but the idea is that we can, we're obviously not going to read the raw medical literature every time we need to answer a clinical question if you're trying to give a patient a recommendation. So all of the raw medical literature is synthesized into these clinical practice guidelines that are very easy to access and read and interpret. So they include broad sort of recommendations that help clinicians make decisions much easier. This is the level of evidence. I think a really good example of it is RACGP, Royal Australian College of General Practitioners, and they have some really good resources on common conditions. So when you're researching assignments, say for example, your falls in the elderly assignment for rural, you might look it up and you might find the RACGP page on it, and it will have a table of recommendations ranked from highest evidence to lowest evidence. And that's really going to make it easy for a clinician to make a recommendation that they know is evidence-based without having to do the whole search and appraisal situation. Okay. And that is it. Whew. So we'll stop sharing. Thanks for sticking it out, you guys.
And then you can start
does anyone have any questions? I'll stop recording.